Our very own Dr. Smita Shah. She is our one of the panelists. Does she need any require any to read a bio?
No need to read.
Does she need any introduction? Okay, I believe it's a lunch time, so everyone is down. सबने खाना खाया कि नहीं खाया जितने भी हैं हॉल में? नहीं खाया? ठीक है. Let me. अच्छा डॉक्टर दो पीपल हैं, दोनों ही नहीं हैं. नहीं तो audience are very low, they didn't had the lunch, seems like. And see, we are going to speak on technology, so I want you guys to interact with the panelists as well, okay? So our next panelist is Dr. Urvi Padik. Ma'am, please. So Dr. Urvi Padik is a practicing diabetologist, endocrinologist since past 15 years. She has worked as a visiting consultant for many institutions and has several publications in her name. Next, we have Dr. Paras Patel. So, Dr. Paras is consulting physician, diabetologist, and he is the director of Health Aura Medical Clinic, Paldi, and his special interest is diabetes management. So today we are going to discuss about beyond leaflets and lectures, innovating diabetes education for digital age. Dr. Nimi, slides. Okay, let's start. Okay. So we are moving from brochures to browsers now. So let's discuss how these things can, how this AI, how these new technologies can impact in diabetes education. So our topic is beyond leaflet and lectures. हमने सब leaflets देख के पढ़ाई किए हैं. When I used to visit hospitals, हम वहाँ से जो उसके brochures और leaflets निकाल के लाते थे घर पे देखने के लिए क्या इसमें key points mention है. So how these things are going to innovate in diabetes education for digital age. So my first question is to Smita ma'am. So what do you see as the biggest shortcoming of traditional diabetes education in today's digital world? Ma'am, here you can. Yes.
Thank you very much. And earlier, before 20 years, when I was diabetes educator and dietitian at time, we often used to give some leaflet to all the patients for hypoglycemia, for diet, all type of the diabetes education leaflet. And we do continuous lectures for that and so many activities for that. But now nowadays are become digital, now the digital world. So obviously there are so many benefits of the leaflet when you are giving to the patients. So at that time, sometimes they read and they have some knowledge about it. But nowadays, people don't like to read. They like to see, So the leaflet become now is not very effective as a education. So sometimes patient used to keep in their file, even they don't bother to see it. And when they have the episode of the hypoglycemia, they call us that what we have to do. So at that time, we remind them that we have given you some materials, you should read it. But they don't bother. So now the leaflet is not so much effective for the educations, and as well as lectures, it's on for the general public. It's not individualized, not personalized. So some patients are very hesitant to ask their questions in the lectures, So nowadays, I think we should promote also digital technology for educations. So I think the leaflets and lectures are some limitations nowadays. I mean it.
Yeah, thank you and beautifully answered. So I can say कि it's like a दृश्यम जो हम देखते हैं सुनते हैं ज़्यादा वो grasp करते हैं rather reading it out. Yeah, thank you, ma'am. So my next question is to Dr. Paras Patel. So, sir, beyond basic websites, Like what are the emerging digital technologies like AI hai, gamification hai. Nowadays we have this
Variables.
bands,
Yeah,
wearables. So which holds most promising things in upcoming days?
Yeah. So thank you so much for invitation. As we see the number of diabetic population is increasing, and most of the people now we get at the diabetes at the younger age. So these young people population, they are more involved with the digital technology. They are more user friendly. So in those cases, they will prefer learning and understanding the disease and its management by using the technology. So variables, as far as variables are concerned, we have at least one step counter, so that will give more accurate result. So there are multiple ways to get it. One important thing which we have learned in the last few years is the CGMS. Yes, CGMS is the use. It is not AI, but it is like technology in diabetes. So use of technology in diabetes management, that is helping, and the most promising and most important is the CGMS.
Okay, thank you, sir. Beautifully answered. Yes, so these gamifications are working these days. So, ma'am, Uzvi ma'am, so what are the potential benefits of using this gamification, especially for the diabetes education purpose?
Yeah, so the basis of a treatment of diabetes is diet, exercise, medication. So this gamification help in all three by changing the habits of the patients. So first of all, if we take diet, then they can have healthy choices from gamification, and they can have a record of their taking diet, calories, all that. And if we take exercise, then they can have their own schedule, own their record, and they can have a encouragement after seeing that how much calorie I have burned. And third thing is they can increase their exercise part also if it is lacking behind. Third thing is for medication. They can have reminders for their medications purposes. And over and above these three, many other things also can be improved by gamifications. Like they have education, they have awareness programs, all that can be given by the gamification.
Oh, okay. Thank you so much, ma'am. So yes, what I can say, with these carrots, with these incentivized things, giving some brownie points is definitely going to help our patients in diabetes education. Okay, moving ahead to this. So next question is for the Smita ma'am. How has the rise of misinformation? We see so many quacks going on. Anyone lose 5 kg weight, she becomes a dietitian. Anyone who's control his diabetes, he is like a diabetes educator or a doctor even. So how these misinformation, how we can educate about this and how we can combat out of it?
So the misinformation is very much common nowadays in the social media, and the influencer make a reel regarding so many myths. The first is that type 1 diabetes is reversible. So that type of the reels are on the social media, and patients are very much impressed of that. And this is the very danger for the patients. And patients used to go in their clinic as well as, and they stopped the insulin, and they went in the decay and the hospitalizations. So there are so many misinformations on the social media. Second is the type diabetes can be reversed after 10 years, 15 years, So there are so many myths and misinformation. So you educate the patients that they check whether the influencer is educated, what the education qualification of that. So I think that to combat with this misinformation, I think the health professional, doctors should prepare the video. Otherwise, their institute should prepare the video for the patients, so they can educate the patients. So main thing, the qualified doctors or the qualified health educators should make this type of the video.
Yeah, completely agree, ma'am. So I can say, check the qualifications, not the followers. So that's matter. Yep. So moving ahead, Dr. Paras, So what's the most significant challenge we face in effectively using digital tools for diabetes education?
Yeah, so most important thing is the awareness. So the we as a clinician or as a paramedic staff, we should educate the patient regarding the proper use of the digital tools. And as madam said that there are a lot of tools, but most of them they will misguide. Right, so we have to give the awareness regarding the proper use of digital tools in the form of proper guidelines, proper dietitian, and proper diet management. Then we have digital tools regarding the reminder for the medications. Then we have digital tools that will remind that will make the log for the our SMBG graphs and all those things. So proper awareness is very important as far as the usage of the digital tools are concerned.
Yes, and I believe ki let's have a goals as well. It should be very personalized goals.
Yeah,
if we
so,
can
yeah.
fix the goal, yeah.
Yeah, so we should have the patient-centric approach. So it should not be like we share the application to all the patient that you follow this application. We can give the guidance regarding the usage of applications as far as the recording of the blood sugars are controlled, and they can make a log for the HbA1c, creatinine, then urine ACR ratio and all those things. So that will be very effective and that is very easily executable in our day-to-day clinic.
Okay, thank you so much, sir. Now we have a Dr. Bansi Sabu with us, so I would like to invite sir on the dais as a panelist.
I will be here for a few minutes because the topic given to me was AI, technology in healthcare. And uses of technology in healthcare is, I will say, underutilized, particularly in diabetes. Yesterday I was listening the debate of two of my friends, Nimi and Rikin. They were talking about the technology where they should use, but in diabetes particularly it is very, very underutilized. Probably we are poor in communicating that. That's number one. The uses of CGM and pump both, we feel that our patient will not able to afford. That's very common myth among all the clinicians. If you ask a cardiologist, will he say ever that you don't need angioplasty? Even a patient is poor, even a patient who is not affording, he is not able to afford, even the clopidogrel or the medication, but still he will suggest that this is what the standard of care. Now, if you see this year new ADA guideline, they had not put just ADA guideline. This is a standard of care. So this is what the minimum the standard you should offer to your patient. This is not that you should be substandard. If you are giving him second best or you feel that is the second best for your patient, it's fine. Yesterday we were also discussing that guideline, we should make it flexible, we should use for our day-to-day clinical practice. But I think everyone should understand that this is what the standard is. If you are as a doctor, you think of that, suppose you are the patient, will you take that care? Will you not take care of yourself by putting CGM? Suppose your someone relative or very close relative of your patient who is type 1, will you not offer him or her a AID system? So think of the best technology use wherever it is possible. In last 25 years, things have completely changed. Before 30 years, me and Urvi Parekh, we are from the same unit. She is 1 year senior to me. We were working in the same medicine department. At that time, our unit was not given even a diabetes clinic. It was with other two units. But we used to go and there was no technology. Even the glucose meter was available to our ward, only one. We were not even asking our patient to do the self-monitoring of blood glucose. Initial years of my practice, we were understanding that technology means self-monitoring of blood glucose. Blood glucose monitoring, something that is the biggest technology which we were having. But now we have connected glucose meter. You have remote monitoring of glucose monitoring. Now the same continuous glucose monitoring you can use even in hospital. Yes, still data is not there to approve it, not for ICU, but definitely those patients who are in the hospital, who are in room, they can be given a continuous glucose monitoring in hospital. There is no need to go a diabetologist to visit a patient 3 times a day. That is what the routinely done by the most of the diabetologists just for their perioperative care or pre or post-op care or sometime for infection or glucose control. I mean, you can just see the reports and you can change the glucose or insulin infusion or insulin injection, and you can instruct directly to the sister or nursing staff. Most underutilized thing is electronic medical records. I don't know why we are not writing electronic medical records. Maybe one of the reason is that we don't have sufficient staff. One can't pay so much for doing it, but there is a national program, Digital Health Mission. So for every data which you fill, actually Government of India pays you. There is a 3 rupees per your whatever your data which you are filling in that. There is a National Digital Health Mission. So there are few electronic medical record system. If you have that system EMR and all your records, if you put in that, there is some money you will get through it from the digital mission, National Digital Health Mission. But the biggest advantage of putting the patients in a digital records, you please go back and see your own data. You will find actually we feel that we are doing very good for our patient, but that's not true. If you go and see your own data, then you will realize actually we are not doing great for our patients. I mean, the same patient who is on different medication, keeping his A1C more than 8.5 for months together, hardly any improvement, his sugar level, he is developing retinopathy, nephropathy, it's progressing, and patient is dying in front of you. So just go back and see your data of last 5 years, 10 years. Are you putting everything on your EMR system? There is a HealthPlix, which is one of the biggest electronic medical records provider in India. I am part of his advisory board. They invited me we just asked that how many patients who are doing actually urine albumin creatinine ratio as per your record data. So urine ACR, 1 million patient prescription we have taken from that HealthPlix. Can you suggest, anyone guess how many people are getting their urine albumin creatinine ratio in India? 1 million patient data from HealthPlix, which is one of the biggest electronic medical record provider, with 100,000 doctors who are using it. We have taken a data of 1 million patients. That publication is already done. It has been done in Lancet Diabetes Endocrinology. I am the first author. How many patients are getting their urine albumin creatinine ratio once in a year? And this I am, since last 20-25 years, Urvi, even when we were resident, from those days we know that once in a year you have to screen the patient for microvascular complication, at least fundus and UACR or at least creatinine. Without creatinine you will not write the prescription. And this we are doing. It's very, very cost effective, 200 rupees for urine ACR or 300 rupees. How many patients? 1 million patient data.
100.
Only 100 patients. So it's 1.2% of the patients, their urine albumin creatinine ratio was done once, which was there in that data. Now, this is the status of, now there may be 3 reasons. You may say that people are not doing it. Second, they are not putting in the electronic medical record system. Third, they don't know the importance of, doing the urine albumin creatinine ratio. If last one is the right answer, then I think what we are doing, this practical diabetology or conferences and so many in a year. Now in a year, how many conferences in India only on cardio diabetes? Is around 3,000 conferences are done. Small or big CME included. That is what the pharma industry data is showing. Around 2,500 to 3,000 CME, which is almost taking care of 100,000 primary care physicians across the country. So it has been informed every physician in India in last 25. Why it is known as CME? Because we need its continuous medical education. So 100,000 physicians round the year, multiple times you are educating yourself, but we are not putting the data in electronic medical record system. Now, while publishing, I first written the confounding factor that most of the patients or doctors are not putting the data rightly, because I can't believe that in India only 1.2% patients are actually getting their urine albumin creatinine ratio, which is getting published in Lens and Diabetes Endocrinology. And you know what people will think, that in India people are not doing an urine albumin creatinine ratio. Forget about everything. So it is must, it is your duty. So I always say that being a doctor, you have three basic duty which you have. One is definitely you are a clinician. Your 50% of the time should go to take care of your clinical patient, and this is what we are doing. It is also for our earning. We have to do for patients' care. This is for what you have become, either nutritionist or a doctor or PhD, master in science, or a clinician. The second most important thing is whatever you see which you feel abnormal, or you should do real world data which should be published. Madam is here. So this is what our teacher, she was our professor. Madam is from BJ Medical College. So now retired, I know, madam. So this is what a real world data publication. I think second most important duty. Most of the time we feel that we are doctor and we should take care of only our patient, but that is not true. I think we should publish. If you are not publishing, this science will die. It is your duty to publish whatever you are seeing, whatever you are, something abnormal, some abstract, some papers, something real world data, whatever you are doing. And unless you put your patient's data in electronic medical record system, I think that is one thing which we should do. It's a society work. You are doing for the society. You are good thing which you are doing for society. So that's second most important thing. And what is third most important thing is education. Whatever you know, you should educate others. This is the only reason the medical science is growing, and it is there. Otherwise, like Ayurveda, like homeopathy, or like other science, particularly in Ayurveda, which we believe that it was our science, in between 2000 years, there is hardly any publication, no research, no real world data, which medication is used, whether it is right, wrong, side effects, nobody knows about it. So this is what we have to do. See, I just given a simple example. GLP had come. Everybody was excited. We all started using clinical research, data, everything. Some scientists told, no, it is causing sarcopenia. With every 5 kg weight reduction, there is 1 kg weight reduction of protein. Now, patients who regain their weight, they gain only fat. They don't regain the protein. They don't get the muscle mass. Think of the guy in 2006, 5. David Nissen thought of all the patients who are getting hospitalized. He started finding the diabetic patients who are getting myocardial infarction and dying in the hospital because of what? And he found that one of the drug, rosiglitazone, for 6,000 patients, he's a cardiologist, following 6,000 patients in a center, Cleveland Clinic, and constantly he was just seeing that which anti-diabetic drugs they are using. And he has done a real world data which he published in New England Journal of Medicine. Glaxo was one of the biggest company in the world, second largest after the Pfizer, from UK. They were manufacturing the rosiglitazone. Rosiglitazone was killed by one paper of a New England Journal of Medicine. He has written this rosiglitazone is not good for the patient with diabetes. Actually, it is killing the patient. So you are not treating your diabetic patients for the purpose of just to control the sugar. It may be very good drug, fantastic insulin sensitizer. What to do? So we learned our diabetes just because of real world data. Electronic medical record is very, very important. Whether you are publishing anything or not publishing, I think this is one minimum thing which we all can do religiously. That each and every patient who is coming to your clinic, all data is not just for their namesake, address, or when we can call back them for their phone number. Do it regularly. That's very, very important. And please publish. Please publish whatever you have. Think of something out of box. Whether your patient is doing good with sulfonylurea, whether they are doing with metformin, how many patients are getting hypoglycemia, how many times we are recalling our patients, whether they are developing hypo or not hypoglycemia. Today, just an example. Today, one of my patients just called me in morning time. Actually, his sugar is getting down. So they stopped Glixembi. Well, patient was on insulin. 10 units of insulin, which was a basal. So probably my team could not teach them properly that when you are on basal insulin, the fasting sugar, if it starts coming down, you have to decrease the dose of basal insulin, not the Glixembi, because patient was thinking in the morning time I'm getting hypoglycemia, and the next medication which we asked the patient to take is Glixembi early in the morning. So they stopped it. So we are not actually calling back our patient. We don't explain our patient probably, and this is all we are doing because we are electronic medical records is really very, very poorly maintained by Indian doctors. There is one more rule in India. If you want to share your data anywhere internationally, so any collaboration which you want to do, you have to take a permission from the government of India. So there is a system. So whenever you, and please do collaboration more and more, but you have to take a permission from the government for any collaboration whenever you are sharing your data to any international body for your publication, for anything. But we can do collaboration amongst us also. It's not necessarily that we have to get collaborated only with some multinational or some American or some European only. We can do and something which we can publish from India also. Like we